Cardiac arrest is a medical emergency of sudden and unexpected cessation of heart function, leading the heart's inability to pump blood effectively to the rest of the body, including vital organs like the brain. The result is loss of consciousness, cessation of breathing, and absence of pulse. Cardiac arrest can have various causes, and understanding them is crucial for prevention and timely intervention. Here are some common causes of cardiac arrest. The most common cause of cardiac arrest is coronary artery disease, which occurs due to the buildup of plaque in the coronary arteries, leading to reduced blood flow to the heart muscle. This can result in a heart attack, myocardial infarction, and subsequent cardiac arrest. Second common cause is arrhythmias, which is abnormal heart rhythms, such as ventricular fibrillation or pulseless ventricular tachycardia, can lead to cardiac arrest. These arrhythmias disrupt the heart's electrical system, causing it to beat irregularly and inefficiently. Conditions affecting heart valves, such as aortic stenosis or mitral valve regurgitation, can increase the risk of cardiac arrest by compromising heart function and blood flow. Another cause is cardiomyopathy. This is a group of diseases that affect the heart muscle, leading to abnormal heart function. Certain types of cardiomyopathy, such as hypertrophic cardiomyopathy, can predispose individuals to cardiac arrest. Other causes include electrolyte imbalances, which is disturbances in electrolyte levels such as potassium, calcium, and magnesium can affect the heart's electrical activity, potentially leading to arrhythmias and cardiac arrest. Drug overdose can also be a cause. Certain drugs, particularly those that affect the heart's rhythm such as antiarrhythmics, can increase the risk of cardiac arrest if taken in excessive doses or in combination with other medications. Finally, electrical shock, as high-voltage electrical shock can disrupt the heart's electrical system, causing cardiac arrest. Cardiac arrest can be attributed to a range of risk factors categorized as modifiable and non-modifiable. Modifiable risk factors include conditions like high blood pressure, which strains the heart and raises the risk of heart disease and cardiac arrest. Elevated cholesterol levels, particularly LDL cholesterol, which is the bad cholesterol, contribute to arterial plaque formation, while smoking accelerates blood vessel damage and atherosclerosis, further increasing the risk. Poorly managed diabetes can damage blood vessels and increase the risk of heart disease. Other factors like obesity, physical inactivity, and unhealthy diets high in saturated fats and sugars are also significant contributors to cardiac arrest risk. On the other hand, non-modifiable risk factors such as age and gender, men are at higher risk, especially after 45 than women, as the risk for women increase after menopause. Another factor is genetic predispositions and family history of heart disease and sudden cardiac arrest, which can also increase an individual's risk and play a role that individuals cannot directly change. Suspect cardiac arrest in any patient who is unconscious and does not have any sign of life. You should only check the pulse. Examine carotid artery for no longer than 10 seconds to confirm the diagnosis, as any other confirmatory clinical features are waste of time. Other assessments that can be useful include patient history. You should gathering information about the patient's medical history, including any previous heart conditions, symptoms leading up to the event, medications taken, and possible triggers such as physical exertion or stress. Electrocardiogram ECG or EKG. This test records the electrical activity of the heart. In cardiac arrest, the ECG may show abnormal rhythms such as ventricular fibrillation or pulseless ventricular tachycardia, which indicate a life-threatening cardiac rhythm disturbance. Blood tests may be done to check for markers of heart damage, such as troponin levels, which can be elevated in conditions like heart attack or myocardial infarction. In some cases, imaging tests like echocardiography, which mean ultrasound of the heart, or angiography that mean X-ray of blood vessels, may be performed to assess the structure and function of the heart and detect any underlying abnormalities. If available, information from witnesses or bystanders can also be valuable in understanding the sequence of events leading up to the cardiac arrest. Start CPR with a ratio of 30 chest compression to 2 ventilation. Meanwhile, try to establish underlying cardiac rhythm quickly to determine the appropriate treatment. In case of ventricular fibrillation or pulseless ventricular tachycardia, Apply pads to attempt defibrillation. One on the right of upper sternum below clavicle, and the other one below at level of left mid-axillary line. Pause CPR to give first defibrillator shock. Give a shock energy of 150 joule with biphasic defibrillator and 360 joule with monophonic. Then immediately resume CPR without any delay until the defibrillator recharged. Continue for 2 minutes before reassessing the rhythm or feeling for a pulse. After 3 shocks, give 1 mg adrenaline intravenous and 300 mg amiodarone. Repeat adrenaline every 5 minutes, and give another dose of amiodarone 150 mg if needed in refractory or recurrence cases. In case of pulseless electrical activity or asystole, start CPR and give 1 mg adrenaline as soon as possible. Repeat the dose every 3 to 5 minutes. Then search for underlying causes to give the appropriate treatment. If the case is associated with hyperkalemia, hypocalcemia, or magnesium overdose, give 10 ml of calcium chloride. If the arrest is associated with tricyclic overdose, give 50 ml of sodium bicarbonate.